So, ladies and gentlemen, thank you very much for coming to this symposium. My name is Peter Calder. I'm one of the orthopaedic surgeons that works at the Royal National Orthopaedic Hospital with my colleague, Professor Hanspal. We're going to talk to you today in a combined approach from teams from both the United Kingdom and the Netherlands. And here comes Rajiv now. We're going to break it down basically into classification and the management strategy for fibula hemimelia. Then we have Marta, who's one of our senior prosthetists from the Royal National Orthopaedic Hospital in the United Kingdom, who's going to talk about the prosthetic challenges that we face with children with fibula deficiency. Simon Shaw is one of our trainees who conducted a study on the outcomes of extension prosthesis versus amputation. I'm then going to talk a little bit about a pressure study result looking at the two different types of extension prosthesis versus prosthesis for amputations. And then we have Ralph Sakkers, who's a consultant orthopedic surgeon, pediatric orthopedic surgeon from Utrecht, and Iris van Wijk, who is one of the rehabilitation consultants, who's going to give the Dutch approach and how it differs slightly to the United Kingdom, and showing how people approach fibula deficiency in a different surgical manner. And then Iris is going to finish off talking about how we're trying to create a group of surgeons and rehabilitation physicians throughout Europe to try and get the combined effort in how to treat these difficult cases. So if we think about fibula hemimelia or longitudinal fibula deficiency, we are aware that it's the commonest congenital deficiency of long bone. Postaxial hyperplasia is probably a more accurate description. And if we think about the presentation of fibula hemimelia or deficiency, we can see there's a wide variation. Here we have an X-ray showing that the fibula is slightly small. Here we have a slightly small fibula. Obviously the limb is smaller itself, but it has a 3-ray foot. This is a patient presenting with quite a significant deformity of knee, tibia, ankle, and foot. And you can see on this X-ray how the fibula is very short. There's been deformity of the proximal tibia. There's coalition in the tarsus and absence of some of the metatarsals, I beg your pardon. Here we have a patient, however, who has complete absence of the fibula, but a normal foot appearance. Here's another example with deformity of the distal tibia, again with a 5-ray foot. And here's a classic example with a deformity of the tibia, deformity of the foot position with the equina valgus, absence of the lateral rays, and again, X-ray position of significant shortening of the limb. So we can see we have a big difference in clinical appearance, and therefore a management strategy for all of these patients is likely to be different. If we go back to where the actual limb starts, it occurs at about 4 weeks within the womb. The apical ectodermal ridge becomes stimulated to allow growth, and this is controlled by a zone of polarizing activity, which is in itself controlled by the sonic hedgehog gene. So there's definitely a genetic control of the outgrowth of the limb, and then the differentiation of the tissues within the limb to give us bone, soft tissue, nerve, etc. But has management changed? If we look at the 1950s, when the first literature on fibula hemimelia or deficiency was published, and the most latest presentations, have we actually changed in our management of these children? The treatment options available would include limb reconstruction techniques, where we use distraction osteogenesis, lengthening both the bone, the tissues, to create a limb of equal length with a good functional knee and a good functional foot. We have extension prosthesis, which accommodates the deformity of both the tibia and foot to allow a limb, again, to be equal of length and to allow walking, or we can perform amputation surgery in order to have a normal prosthesis, and then again to produce a limb of the same length. So if we go back and we just look at the classifications, the question that I ask is, does it help in the decision-making process of how to manage this child? We start with the ISO classification, and here the deficiencies are described on both the anatomic and radiologic basis only. The classically derived terms such as hemimelia, which is commonly used by orthopedic surgeons, so I will apologize for that, are avoided because of the lack of precision and difficulty of translation, and also comparison between different rehabilitation units. The deficiency is described as transverse and longitudinal, as you all know. The longitudinal fibula is either partial or totally absent. The tarsus is again partially or totally absent, and again you have partial or total absent of the rays. However, if we go back to our question, does it aid in the management process, we would have to say no, because it doesn't give a clear indication for surgery. If we look at the orthopedic papers in 1950, we have Coventry's paper, who divided it mainly into type 1 and type 2. The extremity in the type 1 is always shortened, but there is little or no deformity of the foot. In the type 2 cases, however, there is a dimpling of the skin with equinovalgus position and absence of some of the rays. The addition of a type 3 is also if there are additional congenital deformities, potentially of congenital shortening of the femur or upper limb. So if we ask our question again, does this aid management decision? Then yes, it does, where they were talking more of amputation for the type 2, which would go in keeping with a significant shortening and foot deformity. In the 1970s, Coventry and Ackerman classified a more similar classification of type 1 and type 2. Type 1 is split into type 1A and 1B, which looks at partial deficiency of the fibula. Type 2 classified as complete absence of the fibula. And in these, the severe deformity of the foot and limb length discrepancy led to an amputation surgery being the management strategy. So again, does it aid in management decision? We'd have to say yes. More recently, the team from the Scottish Texas Wright Hospital in Texas looked at their review of 30 years experience at one institution, and their proposed classification looked at the length of the discrepancy, associated deformity, and they split those into a percentage of limb length discrepancy. This would then aid a management strategy. And what they seemed to show was that the children with 3 rays or less, or 3 rays or more, I should say, tended to undergo limb reconstruction surgery. Those with foot which only had 2 rays or less seemed to have more prevalence to amputation surgery. So again, if we look at it, does it aid our management decision? Again, yes, it does. The last is Draw-Paley. This is Draw-Paley on the right-hand side of the picture. John Hertzberg's on the left. This was taken in Baltimore. Dr. Paley now works in Florida. But his classification, which he felt is the first classification to aid limb reconstruction techniques, he doesn't advocate amputation very often, but he split down the actual significant deformity of the foot and ankle into various stages, looking to see if there was a deformity of the ankle, the subtalar joint, or combination, and then advocated surgical procedures in order to put the foot in a better position. So again, does it aid management decision? Yes, it does. So if we look at our strategy at the RNOH, the Royal National Orthopaedic Hospital is based in North London. I have to own up that I come from South Wales, so I'm not English, so you can like me. And we have an algorithm for management of congenital limb deformity, which is based on the individual patient. There's a counselling session with both myself and other orthopaedic colleagues about what we can do and what we should do. And this will involve looking at limb reconstruction techniques, looking at amputation techniques, looking at extension prosthesis techniques. They then go and meet Professor Rajiv Hanspal or Dr. Imad Sedki, who is his partner, and discuss the concept of prosthetic wear and application, and then we make a decision on which treatment pathway we'd like to go down. For amputation, our preference is a limb length discrepancy which is predicted to be greater than 20 centimeters. This is after we've explained to the parents how many operations their child is likely to take, what are the potential complications, and also we look at the foot function and whether we can produce a stable weight-bearing limb. So I lay a challenge down that I have never treated a type 1 fibular hemimelia longitudinal deficiency with an amputation. But obviously, there's always an exception, and in these cases, the majority of the fibula is present. The limb length discrepancy is normally between 5 and 15 centimeters predicted, and I would treat a small remnant of a fibula as a complete deficiency, even though technically it would be classified as a partial deficiency. So in these cases, for example, what would you offer? On the left-hand side, you can see there is a partial fibular deficiency, but there is severe deformity of both the knee, the tibia, and the foot, where there is a single ray. On the opposite side, we have a complete absence of the fibula with a 2-ray foot. And in this case, the parents were adamant that they did not want to consider an amputation and wanted to do limb reconstruction. Here's a 3D model of the foot. We did a foot correction aged 18 months to place the calcaneum below the tibia. We then did our first frame at the age of 4 years and 4 months. You can see we've bridged the knee to maintain knee stability because they have an absence of ligaments. We've bridged the ankle to maintain foot position. And at that stage, at the age of 4.5, the limb length discrepancy was over 10 centimeters. We achieved 5 centimeters in the first instance. You can see, having taken the frame away, there's a deformity at the regenerate, and this is a commonly seen problem with absence of the fibula with limb reconstruction, that there's a tendency for the regenerate to fall into valgus, even when the frame comes off and the limb is straight. So we did a second frame aged 6 years and 7 months. The limb length discrepancy at that time was approximately 6 centimeters with deformity as noted. And this time you can see we achieved 6 centimeters of lengthening, and again we felt that the tibia was nice and straight. It was noted that there was geniovalgum, which showed that there was also shortening in the femur, and there's a hyperplasia of the lateral femoral condyle. In order to correct this, we did another operation which guided growth with insertion of a small plate on the medial aspect of the distal femur. One can see that once we've achieved straight a leg, and the screws can see to have diverged during growth, that we remove the plate. However, with time, the deformity can reoccur. And you can see the mechanical axis is now passing outside the lateral aspect of the joint. And you can also see that there's a further limb length discrepancy. So the third frame was placed at age 9 years and 8 months. Limb length discrepancy was 5.5 centimeters, and in this case, we did a bifocal treatment where we lengthened both proximally and distally. Further lengthening of 7.5 centimeters. So this is the current X-ray aged 11 years. This child still is in valgus, is still short, there's still a foot deformity. He's had 14 operations. We've done 18.5 centimeters of lengthening, and there's obviously a long way to go. So if we think about amputation, our principle is disarticulation. We prefer to do a cyme disarticulation because we feel that it is actually quite difficult in the cases where the hindfoot is in severe equina valgus to pull the calcaneum down below the tibia. The timing, does age matter, is a question that will be answered by Simon in our study. And also the fibula analog. Advocates early on said that we should remove the analog to try and enable the deformity to correct by itself, which I talk about the kyphus of the tibia. However, if you look at the subsequent literature, there were several papers which showed that this did not occur, and therefore we just divide the fibula analog, which is a remnant of the fibula from embryological development. The kyphus, again, do we correct or leave? Our principle is to leave it alone because we feel it does not cause any problems with prosthetic fitting. which leads us on to prosthetic challenges, and I welcome Marta to come up and take over.
Hello, everybody. So, as Peter said, we're going to talk about the prosthetic challenges. So, as you've seen, when we have these patients, the other way, there we go, we'll either have an extension prosthesis, so the patient will have to use an extension while they're waiting for surgery or not, or we will have an amputation where we'll have a standard type of prosthesis. So what's the aim? Why are we making them a prosthesis? So what we want to do is we want to extend the length up to the floor so we can level both legs, and we want to make sure that we preserve the existing joints if there's any compromise on them at the time. So what are our problems? What happens when these children come for limb fitting? So we do have a few challenges. We have length availability. We have to remember, is there any surgery plan? Are they going to have limb reconstruction in the future? Are we waiting for a specific age for that? Or are they having an amputation? So we need to have that in mind as well. We need to remember our biomechanics, make sure we respect that. The shape of the limb, and also the suspension. How is this limb going to stay on a little child? So how much space do we have? So we can see a few examples up on the screen, and sometimes we do not have space to fit a prosthetic foot. So we'll just do little extensions, and we will not use a foot when we can, but we are establishing the length so the child can engage in bipedal activities. When we do have space, we will either build a little prototype foot, or we will actually have a prosthetic foot on the limb. When we have limb reconstruction plan, we might end up with something we call the double-deckers. I'm not sure if there's a technical name of, everyone also calls them that. Hop-on, hop-off buses kind of limb. So why do we do that? So we want to make sure that we maintain the plantar grade. So when Peter is doing the lengthening, we did not shorten the Achilles tendon. So we want to maintain that angle. So we do use, depending on the age of the patient and the space available that we have to use components, we might choose different components, but it's an option that we use. Another thing that we need to think about is that sometimes we have a really awkward shape of the residual limb that we need to accommodate. And sometimes these patients are waiting until they are a bit older. So we're talking about they're teenagers already, and you can think about we have a few girls and they want to make sure that their leg looks as cosmetic as possible. So one of the ways for us to accommodate that shape, we use something we call a differential liner. So we have a softer inner layer that we build up to try and make a better shape. Sometimes it gets a bit bulky, but we find good results with it. Other things that we do to accommodate the shape that there might not be the most cosmetic options, but they're easy to use and they're practical for the patients. We do use some openings. So you can imagine that to put those awkward shapes on and off a limb, it can be a bit tricky. So we have 3 different openings. So we might have an anterior opening, and we can use some straps. Sometimes we might have like a panel at the front or not. Sometimes it's just open with straps or Velcros. We can use different materials. Again, we work with the patient and the parents to make sure that we find the best option for them. You can see we do a little bit of a funky design sometimes when that's what the patients want. So we try to incorporate that. So in the same way, we might have a posterior opening. This actually allows us to do a better distribution of pressures at the front. So sometimes you need to use the anterior area to talk, and Peter will talk to you about the pressures on the socket a bit later on. So I think when you have a posterior opening, the anterior panel you can use more for loading, so that's quite good as well, and sometimes for cosmetic reasons as well. And we might have some lateral or medial openings as well. I quite like the one on your right. It has actually a little door stop. So we tried different things on this patient, and it was one that worked the best. So it's a bit, different and unconventional, but it's the one that worked. So sometimes you just need to make sure you work with your patient and make sure you find a solution that works for them. So, everyone is different. So I'm going to tell you 2 little examples of patients that we might have when we have fibula deficiency. So the first one is this patient was presented to us, little girl with a fibula deficiency. So her parents did not want to make a decision for either have limb reconstruction or amputation at that stage. They wanted to wait for her to be older. So what do? We had to make an extension prosthesis. So she had a small surgery to try and accommodate prosthetic fitting. And this was her at age 4. And you can see that it's not a great shape to try and accommodate that. And as she grows, the deformity kept growing as well. So this is her at age 10. And you can see that the limb is getting, and the foot is getting bigger as well as she's getting bigger. And they still didn't make a decision. So you just need to try and accommodate that in your prosthesis. And you have to keep thinking about how can I accommodate this and make sure that the pressures are working well. And you try to accommodate cosmesis as well and try and think of all at the same time. So now she's 13. And this is the model that she uses. So she has a sock fit. It's self-suspending, but she needs to do this to go to school. So first goes the first peel-out liner, then the second. It's like a pull-through thing. And then it's a push fit. And then finally it's on. So it's a lot of process, a lot of different designs and trying to accommodate that. On the other end of the spectrum, we have a little patient that came to us at age 2, and the parents did decide to go for an amputation. So he came to us for his first limb when he was 2, and he adapted to the prosthesis straight away. So although we had a Symes kind of amputation, we still had proximal loading, and you can see it wears a little sleeve for suspension. So again, he's a Symes, why is he wearing a sleeve? So sometimes you need to accommodate for it. But as you can see, this is him at age 5, and he's fully functional. We accommodate the shape really well. His gait is much more symmetrical. He has a little funky fabric socket as well. And he's fully functional. So which way do we go? Which is one better than the other? Should we advise one instead of the other? Let's have a look. Come on, Simon.
Hi there, it's great to be in Cape Town. My name is Dr. Simon Shaw. Just want to say it's a great privilege to work with Professor Hanspal, Peter Calder, and Imed Sedki, who isn't here today, and Marta, of course, on this project. And I'm going to describe to you our outcome study. This was an approved service review. We identified 176 case records with lower limb congenital deficiency, and we identified 38 patients with fibular longitudinal total absence. 6 were excluded because they already had limb lengthening procedures, and 9 were treated with extension prosthesis, leaving 23 patients treated with 25 amputations. We assessed these patients using validated outcome measures. These were the SIGAM, the Special Interest Group in Amputation Medicine, which has a grading of A to F. This really measures walking distance and number of walking aids. The K activity level is from 0 to 4, and is perhaps a more realistic measure of a person's ability to maneuver around environmental hazards, and also measures the quality of the gait. We've also used the PEDS-QOL, which is a quality of life measure used widely now in pediatric medicine, and it has 4 subscales. One is physical, second is emotional, third is educational, and fourth is social. And this is validated from 1 year up to adulthood. We also used a lower limb pain score from 0 to 10. Our amputation group was further subdivided by time of surgery into those who had it less than 3 years and those over 3 years of age. We used a statistical analysis using the Mann-Whitney test for non-parametric data. And these are our demographic results. So on the left-hand side, we have the extension prosthesis group, and on the right, we have the amputation group. As you can see immediately, there's a predominance of males in our amputation group. And I also want to direct you to the median age at assessment, which is 23.5 years in the extension prosthesis group and 8 years in the amputation group. The median follow-up was roughly similar. So on the left-hand side, in the extension prosthesis group, 4 were not offered amputation, and this was mainly because of historical reasons when amputation was not offered, but also because of associated congenital limb deformity, making them not suitable candidates for surgery. You can also see that we have 5 who refused surgery. 3 of these children were from country of origin where amputation is not acceptable. And 2 of these cases were children who basically their parents wanted to wait till the child is older to take more fully part in a decision involving their limb. On the right-hand side, in the amputation group, as you can see, we had 19 early cymes, late 4 cymes, 1 Boyd and 1 transtibial. So just a little bit more detail in the amputation group. We had 19 cymes in 18 patients with a mean age at surgery of 15 months. Actually, our median was 1 year. We had 1 Boyd amputation not performed at our establishment, and this was performed in infancy. The lower limb discrepancy at presentation was 5.5 centimeters with a predicted limb discrepancy of around 20 centimeters. We had 2 cases of longitudinal deficiency of female partial and 7 cases of femoral shortening. In our late group, they presented a mean age of 6.6 years with 4 cymes in 3 children and 1 transtibial at age of 13 years. This case, the child was close to skeletal maturity, and it was also to optimize the space for prosthetic fitting. So further surgery and complications. There was 3 patients here. 1 patient in the early cyme group had a residual remnant of the calcaneal apophysis, which required further surgical excision. And 1 patient required correction of the significant kyphus deformity around 2 years of age of 45 degrees. And our 3rd patient who had a Boyd amputation in infancy went on to have pain and difficulty in prosthetic wear, and this was converted to a cyme-type disarticulation. All 3 cases, the surgery was to promote prosthetic fitting. We had 4 stump complications, 2 recurrent folliculitis, 1 post-operative superficial infection, and 1 wound breakdown, I'm afraid to say, due to parental neglect. So you might not be able to see here, but we have a calcaneal remnant here, just there in the picture. And this is a picture of them in their prosthesis, and it created pressure effects over the anterior kyphus there, but also posteriorly. So it's creating, the extra bit of bone was creating pressure effects both anteriorly and posteriorly, making the prosthesis very uncomfortable. This is a picture after excision. As you can see, there's no more remnant. This is our other case. So this was a case of the child who was operated on in another centre. It was initially operated on at 2 years of age, and they obviously had a tibial kyphus correction as well as a Boyd amputation. And what you can see is the very posterior fixated heel and calcaneum in an equino-valgus position, as the arrow says that. And here we are after operation. So the child has underwent a cyme amputation. There's no more calcaneus. And you can also see the insertion of the 8 plate for guided growth at the knee because of the genovalgum deformity. And this is a picture after the removal of the 8 plate. So here are our outcome scores. As you can see, first of all, we had significantly higher K level activity, 4 versus 2, and significantly lower pain scores in the amputation group of 0 to 7. Of the other outcome scores, we didn't find any significant difference. However, the trend was much higher scores in all the domains of the PEDSQL and also the SIGAM grade. More importantly, there was no difference between the emotional subset scores between early and late amputation. So discussion. There's obviously some study limitations, particularly when looking at retrospective data cohorts, which I have to say are a bit of a nightmare to look through. We've got small numbers, we've got some confounding variables with additional congenital limb deficiency, and also the much younger age group of our amputation group compared to the extension prosthesis group. Conclusions, we've shown excellent functional results following amputation and total fibular deficiency. We recommend leaving the kyphus at time of amputation. And this really gives us evidence for discussing with parents when deciding on treatment. And I think it's a really important point when parents are very emotional. And this just gives us a ballpark to talk about. And also, also importantly, is the adaptable extension prosthesis group also shows reasonable outcome results, although these may be lower. And now I'm just going to pass on to Peter Calder, who's going to talk to us a little bit more about the kyphus and the pressure studies. Yeah.
So we've seen that we've left the kyphus, and we think that the children are doing well. There were a few cases where, especially with the remnant of the calcaneum, there was pressure over the kyphus, so the child was feeling pain anteriorly and posteriorly. So our hypothesis for this small pilot study was that the deformity adds suspension, but pressure is distributed throughout the tibia and not loading on the kyphus. So we did a socket interface stress measurement, and we took 3 patients who had a SIME disarticulation and 1 patient with an extension prosthesis. And we put in 3 sensors, one measuring the pressure at the interface over the patellar weight-bearing surface, 1 over the kyphus itself, and 1 at the end of the actual tibia. And then in the extension prosthesis, we put 1 over the ankle and 1 at the base of the foot. So if we have a look where the location sensors are, this is for a SIMES disarticulation. You can see that the sensors measure pressure and also have the ability to measure longitudinal and circumferential shear stresses. They had to compensate the liner to be able to place the distal sensor. And if we look at the locations in the extension prosthesis, they had to alter the pressure anteriorly over the kyphus as this was not picking up enough pressure. And so that's why in this case the study was conducted at 3 different times. So the results were shown as a graph, and you can easily see where the pressure loading as the patient was walking. And if we look at the results in a specific graph, you can see that most of the pressure is felt distally. You have some pressure over the kyphus and also a lesser pressure over the patellar weight-bearing surface. So in essence, most of the pressure is measured distally. There is some pressure over the kyphus, which may be addressed by casting to increase the patellar weight bearing. But obviously what we have shown in this study that there isn't specific loading over that kyphus, so we feel that it is probably safe to leave that at this time. But with that in mind, I'll now hand you over to the Dutch philosophy and welcome Mr. Ralph Sakkers. And I think, Rajiv, you're going to welcome him first.
Good afternoon. Now, I think I'll start by apologizing for being a few minutes late, but knowing Peter and his efficiency, I wasn't that surprised he'd started. The fact is, as I was walking over to this place, I was held and stopped by the organizers with questions regarding the closing ceremony that takes place in 2 hours' time. But I'm going to invite what I call the Utrecht team. It's about 2 or 3 years ago that they invited us, and they're the ones who created the Child Summit, and since then there's been good communication and collaboration. Ralph, Sakkers is the pediatric surgeon there, so over to you, and followed by Iris, who leads the Child Summit.
Okay. Thank you very much for the introduction. This is a picture of the courtyard of our hospital. It's a children's hospital, as you can see, so we also have children's, how do you say that, things that children like. Actually, this is the Ronald McDonald House for parents that have to stay at the hospital. Oh, sorry. So, the Dutch approach. This talk is done by me as a pediatric orthopedic surgeon and my colleague, a pediatric consultant in physiatrist. This is our picture of our hospital. This is the rehabilitation center. It's in Utrecht. It's a medieval town where the bishop used to live. In the center of the country, and that is actually pretty convenient because we're also the national center for these types of patients, so it's very accessible. And it cannot be stressed enough that treating these patients is teamwork. Here you see part of our team. It's actually much bigger, but as a pediatric orthopedic surgeon, I'm only the minor part of the team, and I think that the most important thing in working with these patients is the indication for what to do. And this is, after that comes the stupid work, and that is for the pediatric orthopedic surgeon. Okay, part 1 is about principles. What we try to achieve in the Netherlands is, because it's so complicated, a multidisciplinary clinics, one-stop shop. So we have a multidisciplinary clinic every other Friday, where the pediatric orthopedic surgeon, the rehabilitation physiatrist, and the CPO are in one room with the child and the patients together. So I learn a lot from my colleagues, and I hope the other way around. And we have also 8 clinics per year with a plastic surgeon who's also present in the room for all the plastic surgery questions. And in this way, we try to have a helicopter view on all the problems that are there. This is made in the ECPOC. We have a presentation on that later. So what are the goals? Optimal functionality, horizontal pelvis when standing on own feet or prosthesis foot, straight biomechanical limb axis, as you can see here, optimal functionality of joints, and active participation in sports. So what choice do we have? This is already discussed. The quality of the joints and the foot is actually the major determining factor for the choice in what type of reconstruction. And it's, as long as you have 20 to 30% limb leg discrepancy, you can almost always reconstruct. So what is the dilemma in the severe deformities, as already explained by my colleague from London? Reconstruction or early amputation and a prosthesis. And I think, actually, I mean, my colleague Dror Paley in Florida, he reconstructs everything. But I think that the choice for reconstruction has a lot to do with the cultural reference, and in some countries also on the amount of money that you have to pay for the treatment. In that case, I'm in a very, if you're born in the Netherlands, you are very lucky because healthcare is a collective responsibility, so everyone is insured and has access to the same amount of treatment. Well, we use the Paley classification, it's already explained, so I go fast over this one. What do we do in Paley type 1? It has a normal alignment of the ankle and subtalar joint. We do lengthening or contralateral epiphysiodesis or combined. If we have a Paley type 2 with a posterolateral tilt of the ankle joint, we do ankle surgery dependent on the stability. So if the ankle is stable and there is a good function, I don't think you should operate every patient. And we do lengthening, and if it's very small, we of course do a contralateral epiphysiodesis. So the big dilemma is in the types 3 and 4. So the Dutch approach, what does it mean? We have a reconstruction algorithm for type 3 and type 4. If the fibula is absent and there is bowing, we are inclined to remove the Anlage to what we think reduces the chance of a recurrence in bowing. But there has, of course, to be more evidence on that. And the other things are dependent on which level is the deformation, and actually it's all the same. You have to align the osseous part on the different levels where the deformation exists. And in this case, it's mainly on 4 levels: tibia, ankle, subtalar, or in the foot itself. What is the end of the range from the reconstruction? That is the super ankle from our colleague Paley. Here, for example, is a Paley type 3. We did an osteotomy, a wedge in here. Now you do a shorty operation since the last 2 years. And we reconstructed the foot under the, aligned the foot under the tibia, and this is the end result. And what you nicely see is that here, from a lateral picture, you have a overprojection of the talus and the calcaneus, and here they are nicely below each other. But then comes the rest, and it is 1 to 2, 4 lengthenings. So it means actually, if you look at what he calls a reconstruction plan, you can end up with, say, 5 to 6 operations, which take you 6 months to a year during your youth. And the question is, do you like that or not? Well, that is a very cultural question, I think. Or you can do an amputation, make a straight leg, and put on your prosthesis and go playing with the other kids. What are further methods? Guided growth, as already showed, if epiphysiodesis with lengthening discrepancies for less than 3 to 5 centimeters, lengthening, or combinations of both. Well, now is the big question. What are typical Dutch people like? This is the copy of the state barge from the 17th century, where the governors used to go to other places on the river. This is how they have their social context. This is me, by the way, here on the back. But I mean, they are down to earth, cozy, and enjoying life as it is. And that makes a difference in the choice of what you do. That means, do you spend 5 years in treatment during your youth, or do you do a one-time solution and actually have the same functional outcome? Oh, this is nowadays, the way we enjoy life looks different, but the principles are the same. So, actually, if we have patients that have a, let's say, prognosis of more than 2 lengthenings, we always explain the full range of technical possibilities, and we offer them patient contact with different options. So we have them contact patients with that are amputated, or have patients that have gone through the lengthening sessions. And many Dutch parents will consider early amputation because they want to have their child a youth where they can play an active sports at school and are not bothered with, let's say, 4 or 5 times 6 months to a year of surgery or in frames or whatever. So the big question and motivation is always the quality of life. And therefore you need patient-related outcome measurements, which we unfortunately still don't have that much in this niche market. But these are 2 patients from our clinic. She had a SIME amputation here, and here she had some congenital amputation already. And this guy was reconstructed for a Paley type 2, and he's training here for the Paralympics in rowing. And if you look at the Paralympics, you can ask, what is the better solution? Having 2 legs or 1 leg with a prosthesis? And I always find this very fascinating. the 2012 Paralympics, for example. If you look at the participants here, this is the guy with 2 legs, and this is the guy with 1 leg and 1 leg with a prosthesis. And here they are at the start for the 100-meter finals. And if you can see here at the beginning, the guy with the 2 legs is really fast at 1.9 seconds. But then at 6.1 seconds, he's already a little bit behind. And at 10.1 seconds, he is the last guy in the field. And the one with the blade runners are in front. And actually here is 10.8 seconds, a new record. Yeah, and it's only 1 second less than at the normal Olympics. And this is patient satisfaction with the prosthesis. So yeah, I don't know actually what is the better solution. So what is patient satisfaction in the Netherlands? It's a functional outcome, short-term and long-term, and social integration in youth and adulthood. Actually, we looked at some outcome measurements, and for this group, actually there was no minus in whatever area the score was. So actually they're doing the same as normal children. So this is the end of part 1. If we go to part 2, we have in the Netherlands, I want to show you some tricks that we have now on the reconstruction. One is to make the lengthening device more patient-friendly. I always had felt sorry during the time of the reconstruction that the children had to walk so long with a circular frame. So what we designed was a circular frame that doesn't go on the patient itself, but it goes on a unilateral fixator. That means that you only need it for the lengthening and the reconstruction, and you can take off the circular frame when you have done your lengthening and reconstruction, and you only need to have something on the leg for the, how do you say that, the ossification phase. So actually, this is the latest prototype. We have here a monolateral fixator with 2 slots in it where you can put in the rings. That means actually, if I go back, the only thing I have to do on the OR is put on the monolateral fixator. It saves me about an hour or an hour and a half time, because this goes very fast. And then in the outpatient clinic, I can take out the body here, put on the rings. And here you see the patient 1 week later. The middle part of the unilateral fixator is temporarily taken out. And the rings are on the blocks here that are in the patient. There are no pins in the muscle compartments, which is actually very nice. The pins are only in the bone, and you can do any reconstruction and lengthening you want. If the correction is achieved, patient comes in the outpatient clinic, you put on the middle part again, and then take the rings off, and you only have your monolateral fixator, and then you can treat the patient until the bone gap is filled with bone. And the nice thing is that all my colleagues in Europe and the United States, when they remove the frame, they have to put in metal pins in the bone because they have a 30% fracture rate. Well, we don't have that in our with our reconstruction, because in the last 1/3 we unlock the monolateral fixator, so that means that the patient walks with total weight bearing, and therefore if you take it off, you don't have a fracture rate of 30% anymore after removing your fixator. So, in case of surgery with Syme or Boyd, again, close multidisciplinary cooperation is very important. And also, not to forget, the planned epiphysiodesis. In my country, still a lot of colleagues forget that you need space for a modern prosthesis. And this space is about 10 to 15 centimeters for a dynamic foot when you're adulthood, or maybe even go to 25 centimeters for a auto-adaptive ankle joint. That means, and we don't use the Paley app, we have our own website where we can see how much growth there is left. And if you look here, it's often at the age of 4 that you have to do a epiphysiodesis at the proximal part of the lower leg, because at the age of 4 here you can see it, there is still around between 10 and 15 centimeters of growth left, and that's what you need for your modern prosthesis. So you should plan your epiphysiodesis after the SIAM amputation around the age of 4 or 5, depends on the patient. And then I would like to give the floor to my colleague, Iris van Wijk. Thank you.
So, back from the surgical details to the holistic approach. As Ralph has pointed out, and Peter as well, is that treating children with limb deficiencies requires a holistic approach or a team approach. I think we all know. In case of an indicated surgery, this slide shows us what we do in the Netherlands. So after the proposition of the surgical intervention, general medical and surgical information was given to the parents and the patient. And then after this, additional education was given on the social impact of the proposed intervention by the social worker in our team and the psychologist, of whom you heard an earlier presentation, and additional education was given by the physiotherapist and the CPO about the physical consequences and the prosthetic considerations afterwards. And now go back. And afterwards, all this information was brought together and we make a shared decision with the child, the parents and the team for either of the proposed interventions or to postpone decision making to a later moment. And to get and to develop the knowledge of our team and keep developing the knowledge of our team, it's not only important to have a team communicating with each other, but also to look abroad around the barriers of your own institution. And therefore we cooperate, for example, with the patient union. This is the one in the Netherlands, to keep pace with their needs and also to talk to other professionals like we're doing today in the ISPO conferences or in the European Pediatric Orthopedic Society or in the ACPOC conference. And our Dutch team is very fond of going to the ACPOC. I don't know if anybody knows the ACPOC or has been there here, or if there are any ACPOC members today, but we really like going there and discussing challenging cases with all kinds of disciplines together, only focusing on children with limb deficiencies. So since we were very inspired by these meetings, we really liked to have a meeting like that in Europe. And as Rajiv already stated before, that's what we did. In January 2015, we had our first Child Summit meeting for European limb reconstruction teams. We did this with 6 European teams, the team of Rajiv Hanspal, but also the Norwegians in this room were there, and 4 other countries. And we discussed cases, we set goals towards more evidence, towards more uniform application of measurements and things like that. So that's what we wanted to proceed from now on. I hope you have heard that our preference is to have a multidisciplinary treatment, that we focus on the family, not just on the child, that the choice for reconstruction versus early amputation is a very personal one, that integrated lengthening frames for patient and surgeon comfort might be considered, and that you must not forget to plan the optimal stump length in cases of early amputations. So, ending this very short presentation, I'd like to invite you, hopefully there will be teams who want to join us in proceeding with this treatment for children with congenital limb deficiencies. I'll put the slide back on. So even if you have a team that's not here, but you know who wants to participate in this, please let us know. And I talked to the Australian colleagues. Sorry, it's European at this moment, but hopefully we will have a global meeting someday. So thank you for the attention. I'll give the summary of which you've heard about today, the English and the Dutch approach together. And I think the floor is open for discussion, which will be led by Peter, Rajiv.
I was just going to say, Australia, we're in the Eurovision Song Contest, so there's no reason why Australia cannot come and join Charles. And in fact, why don't we just go to Australia for the next Charles meeting? But thanks, Harris. That's fantastic.
Right. Thank you very much, all of you all. There's one, I think in addition to the members of Child's meeting, there's also in this world of e-communication discussions on through e-communication on difficult patients that you want advice from, and I think that's also been going on between those have a seat between those 6 countries. So, any questions and comments? Start. Who's going to start? Yes. Actually, I think I'll stay down here. Yeah, I'm bringing it down there.
Thank you, Rajiv. I'm Mike Barkley from South Africa. The area that I work in South Africa, we have a particularly high incidence of FES, which is fetal alcohol syndrome. And we see a lot of these congenital anomalies coming through our clinics. And one of the, Dr. Sakkers in his presentation spoke about the epiphysiodesis at 4 years of age, which as a prosthetist I'm very happy with, but we see these children as they grow up, as they become adults. Some of them become obese or very heavy, and then you're sitting with a problem where you've got this extremely small residual limb carrying a big mass. Often, even if they don't have the epiphysiodesis, these residual limbs don't appear to grow proportionally to the rest of the patient's body. So we end up with amputees who have to carry quite a heavy mass on a very small surface, residual limb surface. I don't know if you experience the same thing. The other thing we experience here in South Africa and throughout Africa is cultural issues. I used to work at a clinic in Namibia for many years, and there we saw a lot of these cases where the parents would refuse treatment, and you'd end up with a child, for example, would walk with his knees flexed, on his knees. So you had to accommodate this limb into a prosthesis. So you'd end up with, which was quite comical, in fact, we used to have, I've got various string of photos where you see the patient at the rear end of the buttocks with the toes sticking out. I just wanted to make those comments.
Would anybody from the panel there like to comment on that?
Beg your pardon? Sorry?
Any one of you would like to comment on further on what Mike Barkley said?
Well, with the epiphysiodesis, you always have enough length left. The normal lower leg for an adult is around 35 centimeters. So if you shorten it with 15 centimeters, you still have 20 centimeters left. And normally that's enough for, I think, but that's, I want to ask my rehabilitation patient. I think it's enough for good prosthesis fitting, but I don't know about the obesity you were talking about. So maybe you can...
I hope I understood the question correctly about the obese children with the small stumps. And yeah. 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 Yeah.
Marta, do you want to comment?
Yeah, I think I recognize them, although we don't have much obese young adults. I only see the children and young adults, but not even the adults. That's sometimes a challenge for the prosthesis also. And yeah, well, you heard some talks about lengthening of small stumps. Yeah. And
Marta,
you have additional options for the prosthesis.
Yeah, so a short stump is always a challenge, especially if you're dealing with an obese patient. But like we mentioned earlier, of course we talked about children only, but it's always about trying to see what is the patient doing. As you said, he has some different gait patterns, walking on their knees before. So it's almost like a case by case and trying to understand what was the patient doing before and what can we achieve. So sometimes it might be if it's a really short transtibial residual limb, you might need to introduce different suspension. You might want to think about a thigh corset if you need it. So there are options, of course, but it is challenging, especially if you're talking about two challenging things, which will be a short residual limb and an obese patient with a difficult gait pattern. So it's almost like trying to think out of the box and combine all those tools together to achieve a good fitting.
And of course, education on not gaining too much weight is very important throughout follow-up. So, but then they have to come to follow-up.
Does anybody have any more questions?
Can I just make a comment?
Yes.
The last thing about your cultural patients. I've had some experience we have quite a lot of Arabic patients that are brought to us from Kuwait and UAE, and they have exactly the same presentation as the patients that you described with the fixed flexion deformity of the knees. And I think it's a very, very difficult surgical challenge because the parents want their child to be normal and they don't want to have an amputation. But from the functional point of view, the only thing that in a lot of the cases you can offer is a through knee type of amputation. And what we have had experience is with the combination of showing them other children with their function with an amputation, in a lot of the cases they've said, okay, we understand now, and even though it's against their cultural beliefs, they do undertake this surgery to improve the function of their child. Now, I don't know if that's helpful, because the only other thing you could do is consider limb reconstruction techniques when you're almost having to put external fixators on to extend their knees to get them straight, to make them stand better, rather than them walking on their knees. And so I think it's a very difficult situation that, I haven't got an easy answer for you. And I think that when the adult comes and they're already obese, again, I don't think that, saying it's a very difficult situation as well. We have quite a few children who've become adults who are grossly overweight, and they've got deformity, they've got difficulty with prosthetic fitting, and it's almost a catch-22. Well, if you lost a lot of weight, we could make this a lot easier, but in order for you to lose a lot of weight, we've got to do something to improve you. I think it's a very, very difficult situation.
Does anybody have any more? Yes. I'll come up there.
Thank you for the nice presentation. I'm Alice from Burundi, and I'm working in an institute of children, and most of them, they have that Fibula, Hemimelia. And you said it's good to focus on family, not just children. But most of the time you find that if you ask children about their view of surgery, they normally don't accept. And when you ask on the view of patient or family, their parent, they will accept it's better they get amputation and get a prosthesis. But as PNO and also physiotherapists in the multidisciplinary, we normally don't just focus on us and also on parent view, because if we just go on our decision, we harm our kids. So I was just asking, is it really good just to decide as the team and also as the parent and forget about children because they also have the right to decide. Thank you.
Yes, who's going to comment at that end?
Good, yeah. I didn't understand the question. Couldn't hear the question very good.
Okay, the question I think
Is it to do with
The family.
if the family says no and the child says no, what do you do then? Is that right? Yes. I think that's in our department. I think obviously it all depends on where you live. In London, it's very multicultural. And one of the big things that we have is that nobody's pressurized into making any decision, and that's why we do see the patients on many occasions before surgery, either limb reconstruction or amputation is undertaken. In several cases where patients can't make a decision, then we have shown today that well-fitted extension prosthesis does very well. But we've also had several children who, when they come to the limb fitting and they see other children running around and they say, well, why isn't my leg looking like that? Why is my foot sticking out to the side? And we've had several children say that they don't want their foot anymore. So I think that there is a time when a child makes their own decision. And also another time when the children make decision about having further surgery is when they reach an age where they can drive, and they find that they get to about 16, and if they have been treated with extension prosthesis, suddenly it's not very adaptable to fit under a steering wheel and use the pedals. And so that's another time when children come and say, actually, I don't want this foot anymore because I can have a better prosthesis and have an amputation at that time. So I think that we're not nobody's pressurizing anybody to do anything. It's all about information. These are our options. This is what we can do. And then I strongly believe whatever we say, they will still fall into three groups. One will say, I don't want an amputation and I want my child's leg to be lengthened. One group will say, we can't make a decision, we want our child to make a decision, which we can use extension prostheses. And one set of parents will say, no, we think the best function for our child will be an amputation. And all of them are right and all of them are wrong. So it's up to you, really.
Yeah, and I think apart from the rules of law, it's all about the content of the education. We guide the parents, we give them all the information they need, usually several times, by several means, movies of other children, direct contact with other children, but we also let the parents, apart from the children, talk to the social worker and the psychologist about their fears, about what's holding them back, and guide them in making decisions. Some parents don't want to make a decision for their child, and we strengthen them to do so if we think it's the best, and if it's a young child, that's what you have to do as a parent. So in different cases, it's all about the education, I think.
Are you a prosthetist? Yes. Well, you're, to my mind, probably the most important person because you're with that child and family all the time. So you're going to get to know them. So when Marta comes to me, and we have our multidisciplinary meeting, Marta will come as the most important person and say, this child is struggling, we can't fit the prosthesis, they want to have an amputation. They're seen, very quickly as a family and a child. And that's, and for example, the case that we showed with the calcaneal remnant, that's my error. I took away what I thought was the whole of the calcaneum, but I left a small area. And retrospectively, if you go through the x-rays, there's a small area of the calcaneum apophysis left, and that's grown into that big lump. But it wasn't until the prosthetist came and said, look, this child's really struggling. And because every time he came to see us, he said, yeah, I'm doing great. But it was the prosthetist who came and said, this child's really struggling, you need to have something done. So you are actually in the most important position, because you can go with them, and then as long as you have good relationship with your surgeon, you can then say, this is when you need to do the amputation or not.
We have another member of the Child Summit here, that's the Norwegian team, and just wonder if they want to make a few comments.
Yeah.
And after this, I will probably pass the mic on to our honorary Europeans.
Yes, I represent the Norwegian team for the lower limb deficiencies because Norway is a very small country. And so this has been centralized to one hospital in Oslo for the congenital lower limb deficiencies. And so Lune is here, is our prosthetist and also occupational therapist who's working with this. So, and our experience is, like the problem about what to choose. We have exactly the same experience as you have in England and in the Netherlands. And I think we're very similar to the Dutch. So most Norwegian families also want to play. And, but certainly, and we also have a lot of people coming from other countries who have other feelings about this. But basically, we have I think that Peter really summed it up very well. There will be 3, when you have these difficult decisions, I mean, sometimes it's easy, you know that you're going to lengthen and you're going to reconstruct, and other times it's easy because there's no way you're ever going to walk on that foot. But then there are these in-between situations. And then I think we have the same kind of experience as you. And sometimes, especially the girls, when if the parents have not been able to choose for them, they will choose themselves when also the boys, because they want to be functional. So then they'll choose to get rid of their foot when they are 12. That's our experience, yes. I don't know, doing that. You want to add anything? We're happy to be a member of the child gathering, and I think we're also I think you're honorary Europeans enough. Thank you.
While walking over with the mic to the honorary Europeans, I will remind people here, some of them might have been present at the launch of the WHO global standards. There is a standard amongst those 60 standards that services in the country should be based on primary, secondary, and tertiary levels. And there is no doubt that that's how it should be. And in countries where people disagree, I suppose you can take the WHO document and say, well, this is what WHO, the experts from around the world, suggested. Who's there?
Hello, hi, I'm Louise Toffs. I'm one of the rehabilitation paediatricians in the team. We're doing the next session, so we'll all introduce ourselves. We don't have any of our surgeons with us. Thank you very much for the invite. We're also looking at, in particular, the middle group, the group that are not quite good enough for an easy lengthening and not quite bad enough for a straight to amputation strategy. And we're struggling with how to measure and compare. We've done a little bit of work in the group, which has ended up mainly being the amputees, because during that small project, which you'll see, we couldn't find many of the lengthening patients. And it's not, this kind of work won't be able to be done in a single centre just because of the numbers. So it would be great to be able to collaborate on some of the short and medium term outcomes in a group that's big enough to detect a sensible change.
I think. Well,
thank you.
Ralph should comment, but I mean, I think that that's the real problem here. If you looked at our data with 176 congenital limb deformities that have amputations in that unit, only about 30 or 36 had an absence of the fibulas, so could be compared as a single group. What we need to know is in those Paley 3s and 4s who are reconstructed, how well do they actually do in comparison to our early amputations? The problem I feel is that, especially if the Dutch and the UK philosophy and probably the Norwegians, it's the Germans are not, they reconstruct, I think, or they're more inclined to reconstruct. So I think that it depends what the numbers are to be able to, as you quite rightly said, to compare what their outcomes are. Because I believe that their foot quality is not going to be adequate to allow them to play sport at such a high level as they are with an amputation. And that's my gut feeling, but it's only a gut feeling. You know, I've got no fact on that. I know that the kids that I reconstruct, yes, they have a leg of equal length, which they can walk on, but I don't believe that it's as good a function, and they do come back with pain as they get older.
I don't think that the Paley 3s and 4s that are reconstructed by Paley will win the 100 meters in the Paralympics.
Can I comment on that? Because we have followed up our patients with not only fibular deficiencies, because they're so few. So they're a little mixed group, but they're below the knee deficiencies and on one side. And so we had about 18 in each group, reconstructed or amputated. And of course, the groups are too small to find that there are statistical differences, and there's a wide range in both groups. So both because we also tested them, you know, with 6-minute walk test and stair test, and so we've also done looked at their performance, and there's just a very wide range. So there are some that are just top in both groups, and some that are doing real bad in both groups. So, but this, of course, is the big question. Can we in any way prove what is best? And what we have concluded after our study is that, well, it's because they have the same quality of life. They're content with what they chose. And that's a very good aspect of life, that whatever your parents chose for you, you're going to be happy with that. You're going to be, okay, they chose that for me, and that's okay. And so those who have been lengthened, they're very happy that they were lengthened. And those who got rid of their feet when they were kids or later, they're happy about that. And they're doing okay. But they have a lower, as a group, they have a lower, of course, level of function compared to the normals. We also compare them to the normal population. But they're equally happy, you can say.
Thank you. There's one question up here. After which, if anybody wants to make any more comments, but I do think the discussion all lends itself towards Child Summit equivalent.
Hello, my name is Jacqueline Tembo from Zambia. I really enjoyed your presentation and just have a few questions, especially for the prostatist. I'm a prostatist orthotist as well, but I'm also a PFFD person, like I have PFFD. And in my experience with people with PFFD and similar conditions, in particular in Zambia, would say we don't have a vast management option as compared to you guys in the developed countries. And I've seen some of my colleagues, and also as in being also a P&O and O, I've seen that we have very limited prosthetic options for them, and they're in a situation whereby they cannot afford surgery or any of those processes that you mentioned before. I just wanted to know, like, how is your variety in terms of prosthetic fitting for people like us?
In terms of components?
Yes.
Yeah, so initially, especially when the child is very young, we don't fit them anything that you wouldn't. And as you've seen, sometimes we don't even use feet. We just have a build-up and a stubby for them to walk without a foot. And they still walk, and they still keep up with their brothers and sisters, and they ride a tricycle, and they don't even have a foot because we didn't have space to use it. Or sometimes when they're small, but they still want something that looks like a foot. I'm not sure if you've seen on the study, it's slightly looks. So we build it ourselves with foam and plastics. So you can do that as well. And so I know that we can fit children when they're a bit older with something a bit more dynamic and energy return. But if you don't have access to that and you use more basic prostheses, as long as you have a good fitting socket and the patient has a good gait pattern, they're going to be doing well. And you know, if you don't have access to those things, you just try and use what you do have. There's always an option for them to use. And although we have access to more things, sometimes we can't use them either because we don't have the space.
It's mostly what, at least in England, they'd call conventional limbs, with not modular. Yes.
Just in response to measuring outcomes, when I did this study, what was interesting was there was a ceiling effect for the PED-squal. You know, all the kids in the early amputation group, they seemed to do very, very well, but I didn't really know how really, really well they did. And I was talking to Iris yesterday about pediatric outcomes and what we use, and you're going to have to use an array of factors. I think the time up and go test is probably a good measure to differentiate some of these children as well. Marta said no, perhaps they're too young to do it. Is it? Yeah. Would you like to say something more about outcomes?
I think sometimes you only see it during sprinting, so in the running, so there are some tests to do so, but even in these cases we see a ceiling effect.
Almost all outcome measures for prosthetics has a ceiling effect. Well, I think it's been a very stimulating discussion. Overall message remains it's multidisciplinary, and communication between centers and specialist centers. I'll just ask if any of the experts here want to make any other comment? Add with anything?
Please join us.
Yeah, thank you.
Yeah. Thank you very much, everyone, for participating, and to all the members of the symposium panel here. And I'm sure they will set up communications amongst themselves. I hope you enjoy the Congress also. Well, it's the last day, the last afternoon, really. Thank you very much, everyone here, and all participants.